but use this one.
That's what we have on the.
Yeah, so this is the more simple design, and so the key parts of this is, obviously, this is the part that goes into the patient. It does have markings on it, so you can see how far in it is, and if you try to notice at the nose. I guess when I was taught this, one good thing to do is to go to the patient and sort of estimate how far it has to be down below the diaphragm, and then you know that you want to get there. If you're only at like 40, clearly the likelihood is it's still in the esophagus if it's in the right position. So there are two channels to this tube, okay? So there's the big channel, which is the suction one, but very importantly, and this is my pet peeve, is this blue port, okay? This is called the sump port. This is for air to flow in through here, okay? So if we don't have this and you just stick a simple tube into somebody and you suck on it, it will empty out the stomach, but then it will then suck once the stomach is empty, it will collapse and suck up onto the tube, and then obviously nothing will happen. And even if the stomach fills up with fluid, because it's essentially wrapped in the stomach mucosa, nothing will come through this, and it's not a working port. So that's why this design of the blue port is there, and this is to provide, allow air to constantly, essentially be sucked in through here, and so that the tube doesn't get sucked up against the stomach wall and continues to function. So I don't particularly like this thing. So this is, I guess, designed by a nurse who was tired of a content backing up through this blue port, and she's like, well, I'll just stick this on there and there. Therefore, nothing will back up, but it's supposed to be designed so that air can still get into there.
Okay.
So one of the first things that I do when I go to see a patient who has a non-functioning tube, or if I'm not sure I believe that it's working, is one, if you can hear the whistling, if the suction is on and you hear air whistling through that, you know that you have a functioning tube. If you don't, and particularly if you see fluid backed up through here, the likelihood is there is no sump port, and therefore it's at risk for getting clogged up against the stomach wall. And so the thing to do is to take the piston syringe, which really should be at the bedside of every patient with an NG tube, and then basically you just inject air here. And what you'll find oftentimes is as soon as you inject air, you'll start seeing fluid coming back up. Okay. And so my other pet peeve is, so for some reason people are shoving this thing in so hard that it cannot be removed, which means you cannot flush it. So my preference is to not have it on there, or if you're gonna if for whatever reason you feel you have to do it, to put it in there gently. But the thing is, and then the other thing that I find is people, oh, it's leaking back, so I'm gonna put a rubber glove on it to catch everything, or whatever. And so instead of fixing the problem, you're just it's like hiding the problem. So you're like, oh, well, I'm gonna take care of that back flow, and I'm just gonna clamp it off or whatever. I've seen people tie knots in this, and basically you've created a non-functioning tube, and so instead of addressing the problem, you're exacerbating the problem. So really important to keep those piston syringes at the bedside. And every time I see a patient, I essentially always flush it to make sure that it's working, and I listen for that whistling sound. Because when the patient is on suction, it may continue to function, because when we first put it in, this blue port is patent and it's sucking. But then there are patients who we say, yeah, get them up and out of bed, so it's okay to clamp the tube, let them walk around. And during that time is when things may back up into the blue tube. And so you want to always try to keep that, so when they get back in bed and you hook them back up, it's a good idea to flush that again to get the air circulating. So this is my big thing about these tubes, is to understand the importance of this blue tube and why we need to keep it patent. And if it's coming back and causing an issue and soiling it, you want to fix the problem. Don't just try to bury the problem. So that's my number one thing. As far as insertion of G-tubes, so it's very uncomfortable for patients. I feel really bad for them, and I always tell patients, once it's in there, you want to make sure it stays in there, because the worst part of having an NG tube is the insertion. I know it's not comfortable once you have it in, but the insertion is the worst part. And so the worst part of the tube, because I know that a lot of people are coughing and whatever, and what you don't want to do is just shove it in there, because if they're coughing and everything, that means you're going down the wrong place. And so the way that I do this, and I think it's much easier on the patients and they're much more likely to be cooperative with you, is, and sometimes you can, if you're feeling really nice and you have the time to do it, is you can soften up the tube. The hardest part of the tube is when it gets to the back of the nose. So it's pretty much a straight shot from the nose to the back, and then it takes essentially a right angle down. And so when you're going back there and it's hitting that wall, that's when it really hurts. And so, so you can soften up the tube by soaking it in warm water, you know, trying to warm it up with your hands, trying to give it a little bit of a curve so that when it gets back there, it sort of easily goes back. But if you warm up the tube with warm water, it makes the tube softer, obviously. And so I'll tell the patient, and you always prep them ahead of time, and you tell them what it's going to be like. So I say to them, I explain to them the hardest part of this tube insertion is that when it hits the back of your nose/throat. And it's gonna hurt, and you just have to get through that. And I say, I'm gonna push it back there. Once I get around that corner, I'm gonna stop. So once I feel it come around that corner, I don't keep pushing. I stop and I say, I'm gonna let you catch your breath. So I tell them that I'm gonna push around that corner, and then I'm gonna stop, and I'm gonna let you catch your breath before we progress. And so you do that. It's horrible. Then you give them a chance to, you know, sort of calm down everything. And then the instructions are, then you're gonna have them swallow. So I say, when I say 3, I'm gonna want you to swallow, and that will help the tube go down the appropriate place into the esophagus instead of trying to get it, and then instead of shoving it down into the lungs. And so I give them a chance to catch their breath, and then I say, we're gonna do this together, and then you have them swallow, and you can usually see when a patient is swallowing. So when you see that they're actually swallowing, that's when you wanna go. And you don't want to, and don't go super slow. I mean, you want to try to go fairly quick. And then once it's sort of past, you know, the tracheal, like you're not going in the trachea and going in the esophagus, usually they're okay by that. And then you're not going to get the coughing and stuff like that. And so then it usually goes pretty easily. And then you go in until, you know, you get to, I don't know, 65. And then either you'll be getting a product pack, or you're going to take your syringe and you're going to listen for the insufflation to make sure it's in the right place, secure it to the nose. So a lot of times with these small bowel obstruction patients, and you're putting in the initial NG tube, I'll do what's called the gastrographin challenge for small bowel obstruction. Typically, I think we've been doing it, and you guys haven't been doing it, but just so you know, what we're doing is, after somebody's been on suction for a few hours, we'll give the gastrographin challenge. I put like 90 cc's of gastrographin and 50 cc's of water, so we're only talking about 140 milliliters, so it's not a huge volume. But the thing about the gastrographin is that it is very, very bad for your lungs. So if somebody were to aspirate gastrographin, they're gonna get a really bad pneumonitis, and they could be potentially really, really sick, because you really are damaging their lungs. So we always get an x-ray if we are gonna be doing a gastrographin challenge. So we have to document that the NG tube is in the correct position before we push that gastrographin in. If we're not doing a gastrographin challenge and we're just trying to decompress, if you put it in, you get a good air, whatever, and things are sucking back, you don't absolutely necessarily need to get that x-ray, but if you're, you know, very confident that we're in the right place and it's doing what it's supposed to be doing, okay? So just that important difference between gastrographin and, say, barium. I know we all think barium is terrible. Barium is bad in the belly, but it's not as bad in the lungs. But gastrographin is okay in the belly, but it's really bad in the lungs, okay? Anything else? Anybody have any questions about this tube? So you guys understand that there are the 2 channels here. This is for air, and we want that to always be patent. And if you feel like it's not working, the good thing to do is to flush it with air. Never flush anything else through there. I'm hoping it's not you guys, but like a few weeks ago, all in the same day, the first time I came in, what was it? Somebody had, instead of this connector, somebody had done this and had this dissection.
Oh.
So clearly it wasn't working. So I told the nurse, that's not how you do it. Suction comes to here. This is for the blue port. I go and I come back at the end of the day to see how the NG tube is working. And now I come and I find that the suction is hooked now to the blue port, and this is clamped off. So these are the sorts of things that I get really, really frustrated with, because This is a horrible, it's terrible for the patient. It's really, really important, especially if we're talking about surgery patients who are coming in mostly with GI issues. And this is the one thing that's gonna make them feel better or is gonna get them through that. And so to have a non-functioning G-tube, NG tube is torturing the patient with absolutely no benefit. And this thing is an easy fix. Like if you don't want the bed getting soiled because things are backing up, just flush it with the air, and typically that makes it work, unless it's in the wrong place.
Do you having it sometimes we get patients from the ED.
Yeah.
And they have very small NG tube.
This thing? Oh, the small bore?
The small bore. And then sometimes, there is not too much output from that one because it's very tiny.
Yeah.
And so any specific that you want us?
I mean, typically I like the larger, like the 18,
Right.
16. I think I went through this the other day. Because if they're gonna get feedings through it, it has to be the iris, the small one.
Oh yeah, I know, but not this one.
No, I
not
think
just for suctions.
No, I think the decompression and stuff one. I think they just
so this
don't
is just like
put it in.
The nurses or people downstairs are like, oh, I'm gonna be nice to the patient. I'm gonna put in a little tube. And they don't understand that that's not being nice because there's a higher chance that patient's gonna have to have a second tube because the first one doesn't work. So typically I try to do an 18 if I can. A small one will work if the only thing in their stomach is thin liquid, but once you start, getting thicker stuff up there, it's gonna clog. Just briefly, there's this other tube, which you guys are hopefully never putting in because they're not stocking it. I don't know why they got this. I'm guessing it's more expensive than that one because it's more complicated. And
I hate that.
I have an issue, so it's a whole different syringe system on there. And so I guess these are essentially, this is like useless. It's all going into the same channel. So why anybody thought you need to have two, you're never gonna be sucking and giving stuff at the same time. And I believe this is the airport, which I have not figured out a way to flush that. So the problem is that I don't know how to, to fix the problem if it's not working or to check to see if the airport. So you can see that from here that the smaller one must be the sump port, and that's going to this little open area. I don't know, have you guys ever seen anything leaking out of here, or have you ever seen anything going on here? Right, so I don't have a way of problem shooting this tube or even checking it to see whether or not it's working appropriately. So this is it's fairly obvious, this is the suction because the suction tubing will only go on this one. This is I guess like a lure lock thing to give stuff through. And then you just toggle this if you're using this or you're using that. This is like I guess to save you guys the problem of switching.
Well,
tubes.
if you push something through the one, it'll come
It'll
back.
just suck out. Yeah, if you
don't have it shut off.
If you don't have it shut off, but again, that's like this is a stupid, expensive thing. But I guess that we do see people arriving with this from the ER. It seems like this is what you're talking about with the smaller bore because it feels like this is a 14 French, so. Any questions about that? Okay, so the main thing about putting in the NG tubes to not get failure is if the patient is coughing, gagging, whatever, by shoving it in, you're unlikely to get it in. And then the problem is I come around and then they refuse to let anybody else try because they've had such a bad experience the first time. So you have to really try to get the patient to cooperate. And again, the important thing I'd say is giving them a break after you get past that corner and then having them swallow while it goes down, okay? And then the other thing is, I know a lot of you guys do this, but gravity thing. So if the tube is down here, it's more likely that the liquid's gonna come into this blue port where we don't want it to be. So it is a good idea to try to secure it up a little bit higher to try to prevent the gravity issue of encouraging stuff to go into this blue port. Again, can't emphasize enough the importance of this blue sump port and it being patent. And again, please, even in this one, don't shove it in really hard. it's like really hard to get out if somebody's really shoved it in there, and then it breaks off, and then we're like, oh, we have to put in a new tube because we can't use it anymore. I guess the other thing we're gonna talk about briefly is, hello? I think probably you guys already know about this, I'm assuming, how to empty it and everything. So it's gonna come up to you like this, secured to the patient, draining something or other. So it is a one-way system, so the good thing is nothing should be backing up into the patient, so you don't have to worry about that. So the main thing is emptying it, recording it, and then I guess the one thing that I guys want to educate you guys about is when you compress it. So this is like, it wants to be in this shape, so that's why, so this is a negative pressure system, so that once you squeeze it and cap it, it is pulling on whatever's in there to pull anything out of the abdomen. So if it's occluded, it'll hold the suction. So once it's like that, even if you squeeze it, you're not gonna squeeze anything back in it, so you'll have to do that. Just gonna click that off, and then you do that. And then it should hold until, and so like I said, it wants to go back to this. So I'm gonna say, so what I don't really want is, so there's some nurses that I think will do this. And this doesn't really, it's not, I don't think it's as good as squeezing it this way. I think the suction, and it's gonna work much better this way. Some nurses, for some reason, I think they think it looks prettier to do it this way, but I, ask that you guys not do it this way. It's not as, I think it's not as effective, and so when you squeeze it, it should be that way, because see how that like rebounds like that? This way is, I think, probably less effective as far as providing that negative suction, okay? We do sometimes strip it. I don't know if you guys do that. Sometimes you can try it if you feel like it's clogged or something, you see some blood clot in there, you can strip it. That's done by holding it and then squeezing along here. To do it really easily, I'll just take an alcohol pad, and then you can, then it slides really well, and so you slide it down there and you release, and a lot of times it'll dislodge any little clot or something like that, and hopefully get it into the thing, and then it will start working again. Sometimes it hurts the patient though, so if you're doing that, it probably means that yes, it's working, there's just nothing left to drain, and it's now sucking on tissue in there, and then it hurts, so then you go, okay, we'll just leave that alone. Okay. And then you guys are giving the education to the patients when they go home about that, so that's important. I know that for my breast patients, they should all be going home with a sheet that actually explains it, but it also has a place for them to document how much is coming out every time they empty it, and they're supposed to date and time it. So for the breast patients after mastectomy, I really like them to go home with that. So you give them the instructions and show them that sheet of paper so that they understand everything. Okay.
How much would be concerned? How much, how often?
So
it gets.
Typically, it's not so much about, well, it all depends on what's coming out.
Right.
So if it looks like frank blood, then we're going to be concerned. I mean, immediately afterwards, it's not, but after, I guess, like during the second shift, if you're still constantly emptying it and it looks like frank blood, then you should let somebody know, and then we would want to check a hemoglobin or something like that. So if you're getting like 100, 100, then yeah, we should probably be a little bit worried about their hemoglobin. If it's Kool-Aid looking like stuff, it doesn't, we're not really concerned about the volume. And if it's yellow, we're really not concerned that, nothing like emergent that you have to call somebody and let somebody know. You just want to make sure it continues to drain. But it does, and so if you're seeing that things are starting to leak out from around there, then the question is, are we able to keep up with emptying this? Because once it's full, if it's not emptied, it's like putting a cork in the hole, and then that fluid is accumulating, and then it will start to leak out through the astral site. And then again, that's like, okay, if you're seeing a lot of here, then you have to think, what can I do to problem solve this? And that's either this isn't working, so you can try stripping it, or the patient is just producing so much and you can't get in there frequently enough to empty it, and at that point, a lot of times we'll either put on the hemovac container, which is much higher volume, so that you don't have to be emptying it every hour, and more likely to function. And other times, if I don't feel like I need it to be on actual suction, we try to find a bag so that it's just gravity. So it's basically overflow fluid that's coming out. So patients with ascites will often create a lot of stuff, and if you keep sucking it out, they'll just keep producing more. And so in those situations, we'll try not to completely drain everything out, and that's where sometimes having a bag to gravity, but then the issue there is always finding a way to connect this to something that they can drain into. But I used to be able to get those urostomy bags, but it was always the issue of finding the connector so that we could do that. But in somebody who has a really high output of yellow serous fluid, rather than putting on a suction device, then sometimes just putting it to a gravity bag is going to be better. Okay. Anybody have any questions or issues, concerns, things they want to do that I don't want to do? Anybody have any problems that they run into that they're like, I can't fix this and I don't know what to do about it?
The only things that I encountered a lot of times is the leaking around the site.
Of the JP?
Of the JPs.
Yeah, so I would say in those situations, it's either it's not draining adequately, either because you can't keep up, and so if you're seeing that and every time you come in, the bulb is like this and you're having a lot of leakage, it's because there's too much fluid that needs to be evacuated, and we don't have the people to come by and empty it as frequently as would need to be. And in those situations, I'd say getting a bigger container or putting it to gravity may help. But unfortunately, or if it's like, if the incision is really big, then you could always ask the PA or the surgeon to put in another stitch just to make it a little bit tighter.
Okay.
Okay. Any other and then if it's really, sometimes we'll put like an ostomy bag around the opening,
right,
just to help to catch the fluid. Okay. Anybody else with anything want to add? Frustrations?